So I'm scrolling the MR images, hide the lesion. Coronal haste. Axial haste. So obviously the question is it something benign? Is this something malignant that we need to plan surgery for, or how do we need to take care of this? Any thoughts?
It looks really bizarre to me.
Yes.
Dalal says benign.
Yes.
Fibrocystic disease.
Okay. So yes. So I think even if we can't give a specific diagnosis, this is a very rare entity. Only a few case reports are in literature, but I think the important thing is to, I think, just analyze the images and appreciate that it looks benign. It's just a cluster of cysts, and what we have intervening is just looks like normal liver parenchyma. And then I had the diffusion. I can show you the diffusion weighted images. There was not a whole lot of restriction. So just T2 shine through from cystic areas, but not a whole lot of, restrictions. So even I didn't know at that time what this entity was, but was a little confident that whatever it is, it's something benign. So they did a percutaneous needle biopsy because we weren't sure what this is. So this is the biopsy report on this case. So it showed benign group of hepatocytes and large fibrotic areas containing bile, ductular proliferation, and microscopic cystic spaces lined by attenuated simple cuboidal epithelium, and no malignancy identified. I think there's some suggestive words in the biopsy report, but as I said, it's a rare condition. So this is what is known as multicystic biliary hamartoma. And I came to know of this entity from Anu's lecture that she took for APDR on cystic hepatic masses. So I think that's how we all learn when from these great lectures. So it's a rare hamartomatous nodule of the liver. It was first described in 2006, so fairly recently described entity. As I said, there are only just few case reports in literature, but it has this classic honeycomb-like appearance where you have a cluster of cysts with septations within. And on path, these correspond to, so the cystic areas correspond to these dilated hamartomatous bile ducts, and they have fibrous septae within them, which is nothing but just scarred fibrotic liver parenchyma in between. And these are some, because I thought there was a good correlation between the path findings and the imaging findings here. These are the specimen images that I've borrowed from these case reports on, and it clearly matches like these cystic areas, which are dilated bile ducts and intervening fibrotic liver parenchyma. So a very nice rat path correlation here. And these are often peripheral in location, as in this case. A lot of them are described in the left lobe of the liver, but I don't think there is any segment specification for these lesions. They may be partly exophatic. These are benign. And the important thing here is that we should not confuse them with neoplasms such as biliary cystadenoma or cystadenocarcinoma. And we've seen a few examples in this conference. These are more like unilocular lesions with either septations or solid component towards the periphery of the lesion. And the other closest differential diagnosis would be ciliated foregut cyst, but these have classic location in the segment 4, and they're subcapsular in location. And another differential is again a very rare entity known as peribiliary gland hamartoma or biliary adenoma. The only difference between these two, like a multicystic biliary hamartoma and biliary adenoma, is in these, the ducts are now dilated. So it looks more like a solitary lesion. And on path, there is inflammation and fibrosis. So this was the case.
Very cool. I have some questions for you. Like, you know, when we talk about biliary hamartomas, like sometimes what I basically have been doing is calling, you know, very small cysts, although some people also call those biliary hamartomas because they're lined by biliary epithelium, like just the regular cysts that we see. And then when they become larger, that's when other people also start calling them biliary hamartomas. Is this related to that type of hamartoma?
So this is also a hamartoma, but yes, there is a difference. So biliary hamartomas that we classically say are those benign cysts. They are in a biliary distribution, but they don't have any communication with the bile ducts. So I think there is a difference at the path level here. It's a cluster, it's a localized hamartomatous disease, and you get dilated bile ducts. And in a biliary adenoma, again, it's a localized lesion. It's not like scattered multiple cysts. This is a localized lesion where the ducts are not dilated, and on path they see a lot of inflammation and fibrosis within the lesion. So that's the difference between these three lesions, but they're all hamartomatous. They're all lined by biliary epithelium.
Okay, and then this one just has like a lot more fibrosis in it also.
Yes. This intervening tissue that we are seeing is just fibrotic scarred liver parenchyma.
Cool. I've never seen that, and hopefully I'll remember it next time I see it.
But I think it has just an ant-mini appearance. It's just there are very few. I think when I was doing the literature search, there are only like 10 case reports so far in literature. But Anu showed one case in, so she might have some more cases in her collection.
Cool. Okay, keep going.
Okay, next one. Okay, so this is again a female patient, 51-year-old. We have a CT here, contrast enhanced CT. I'll scroll from down up.
This looks like something more malignant, even with peritoneal nodules and things.
Yes, so definitely a malignancy with peritoneal nodules, big heterogeneous mass from the pelvis extending into the abdominal cavity. This is the sagittal image. So this is again a rare entity, and I don't think we can make a prospective diagnosis, but there were just some clues that can point to the diagnosis and just some interesting points about this entity. That's why I just selected this case to present. So the uterus.
I guess I would have proposed maybe a leiomyosarcoma.
Yes, that's one of the an important differential here. So the uterus is enlarged and has multiple small lesions, which when we see uterus with these multiple lesions, we think of leiomyosarcomas, but there's something unusual about these leiomyosarcomas. They have this more tumor gray-like appearance and enhancement, and one of them is pedunculated, growing into the endometrial cavity. And this mass, not sure if it's just arising exophytically from the uterus or it's definitely in the right and growing in the right adnexa, because we can see the adnexal vessels here draped along the margin of this. And then we have the enlarged gonadal vessels draining up here. So differentials for uterine sarcomas is where we are heading to. So closest differential would be a leiomyosarcoma. But on path, this one turned out to be a PEComa. So
whoa.
It's a malignant PEComa. And this is a nice article from AJR that highlights all the important points about metastatic primary and metastatic malignant PEComas, which stand for perivascular epithelioid cell tumors. And again, these are rare mesenchymal neoplasms that arise from the epithelioid cells, and pathologically they express both melanoma and smooth muscle markers, and that's how it's diagnosed on biopsy. The other name for this is primary extrapulmonary sugar tumor, and I think in between we had a discussion on sugar tumors, so I saw this case and I thought, okay, I need to read about sugar tumors. So they are called sugar tumors because they have high cellular glycogen concentration, more common in females, and the malignant ones are very aggressive with poor prognosis, and 10% are associated with tuberous sclerosis complex. So the PEComa family comprises PEComas of the lung, and some of these are like entities that we have heard about and more common, more familiar to us, lymphangioliomyomatosis, LAM of the lung. You can have benign PEComas, including clear cell sugar tumor of the lung, which is again a rare tumor, and you can have malignant PEComas. PEComas of the kidney include classic angiomyolipoma, epithelioid angiomyolipoma, oncocytoma-like angiomyolipoma, and lymphangiomatosis of the renal sinus, and some other rare tumors. So looking at the distribution of these lesions, these are most common in the retroperitoneum involving the kidneys. And another common location to remember is uterus, as in this case. So imaging features are non-specific. As I said, it's hard to make a prospective diagnosis, but some things that can suggest the diagnosis is these masses, though they look malignant, they don't invade or infiltrate the surrounding structures. And these are usually show intense arterial phase enhancement, like how angiomyolipomas and other tumors show of this category. So important things here are PEComas should be considered in the differential diagnosis for large renal masses, especially when they are arterially enhancing. And obviously we cannot exclude RCCs and lymphomas there, but something to keep in mind with large arterially enhancing renal masses. And uterine PEComas mimic fibroids and leiomyosarcomas on imaging. So these are just good differentials for such a presentation. And they will be bright or hyperintense on T2 weighted images. So when we have a differential for T2 hyperintense uterine masses, we commonly consider cellular leiomyomas and sarcomas, which are more common. But one thing to include in this list of differentials is PEComas too. The metastases are common in lung, liver, lymph nodes, and peritoneum. So just to look for these when we are reading these cases. They're often surgery is the treatment of choice, because a lot of these, especially the uterine ones, are thought to be just leiomyomas because they don't have any specific imaging features. So they often undergo surgery. And for the malignant ones, we need some form of chemotherapy and radiation. And an important thing to remember about the treatment part is that they have, a lot of them show good response to these mTOR inhibitors. Which is a protein kinase, and the drug is rapamycin. I think that's all on PEComas.
Are you ready for my next case? So sorry, I was actually just playing. I was looking up my YouTube video on my PEComa that I showed at Case Conference last time. So I'll just paste it in here if anyone wants to see it. But it's also on the website. But so yeah, one of our first Case Conferences, I presented a huge renal mass that was growing. Like it looked like an RCC, and it was growing into the renal vein and up the IVC. But it was in a patient with multiple other angiomyolipomas. So we were confused about whether or not it was a renal cell carcinoma or if it was an epithelioid angiomyolipoma, which tends to mimic renal cell carcinomas and have less fat. And that, anyway, got resected, and it turned out the final path said PEComa/epithelioid angiomyolipoma. So I put the YouTube over here if you guys want to watch it later. But yeah, that's kind of when I first learned more about these PEComa family and like how it's all related to these tuberous sclerosis AMLs. And I think it's hard to make it prospectively, but I do think that if you have a patient with tuberous sclerosis, instead of just, and you have a more solid appearing mass, it may be one of these kind of PEComa AMLs rather than, or epithelioid AMLs rather than definitely an RCC.
Yeah.
Cool. But I think in general, it's hard to prospectively call it PEComa.
Yes, yeah, it's a rare thing, and not specific, no specific imaging findings, but some points which are important to remember.
Yeah, and then they're not necessarily malignant, but yours was malignant, right? Because it had the...
Yes, this was one malignant. Yeah, not all of them are malignant, and it all depends on the path, like the number of mitotic figures they figure out or amount of nuclear pleomorphism they have.
Awesome. Victoria, do you want to go?
Sure. Can you hear me?
Yes.
Yes, sure. So I'm going to have to use PowerPoint for today. Case of undisclosed name. I mean, and gender is irrelevant, but this patient presented with this region of the gallbladder. So thoughts?
Looks like there's some inflammation around there. You're kind of breaking in and out. Oh wow! And then there's.
So you can see this.
Victoria,
you see it?
At least you're breaking.
Can you see it or no?
Yeah, but you're breaking up, and Rupa also says that she can't hear you well. Like, is your internet okay?
Is it? my internet. That's why I have to use it because I'm on a not as strong of an internet as I usually am. Is there a way for me to? Can you see my screen? Or,
yeah, we can see your screen. It's jumping a little bit, and your voice is in and out. But we do already have some diagnoses coming in. So,
okay.
Kedar was wondering if it's Xanthogranulomatous cholecystitis. And I was wondering about that.
Right. So that
gallbladder cancer.
is something like this. The first thing is Xanthogranulomatous cholecystitis can look very similar. But what about this bright spot? Can you hear me?
Yes. So, like, is there a gallstone in the middle of it?
Yeah. So that's a great thought. This is a very rare entity, but let me just show you the path. The patient went for surgery, and this is it. This is on coronal, and this is resection of this little mass.
Wait, is that a pseudoaneurysm?
It is. It is pseudoaneurysm. So the path was. So the surgeon didn't take, unfortunately, the pictures of the mass, but she said when she opened the mass up, basically it was all little stones with surrounding inflammation. It was just like this big inflammatory mush. And this is a pseudoaneurysm of a cystic artery, which, and this is the path. And this actually is there's a case report that I can show you somewhere. Here we go. So this is a case report that talks about cystic artery pseudoaneurysm, which is a very rare complication of xanthogranulomatous cholecystitis, and you can see that their case is very bleeding. In our case, patient did not have bleeding. She just
Okay, Victoria, you're really breaking up.
let somebody else share, and I'll actually just call in since it's just my voice. I don't know why it was working fine for another meeting.
Okay. Okay, can you guys see my screen? You guys can see this, right?
Yes.
Okay.
See.
So basically, this was a patient who had a prior history of endometrial cancer and had a lymph node, like some metastatic nodes. So you can see that there's some clips here. And she had another part of her history, which I'm going to keep from you, and came for a follow-up. And we're seeing this little thing here. So any thoughts about what this could be? I actually don't know what this is. This was like a little mystery to us. We just kind of had some theories. But one of the other things that we noticed was that the bowel was kind of focally dilated around this area and then maybe narrowed here and then dilated again and then narrowed. And so we were wondering if the bowel was kind of abnormal there. And I do have we were looking at a prior exam, same patient. And we saw again that there was kind of multifocal areas of like bowel wall thickening, dilation, a little bit of narrowing here. So I saw some people were chatting in. Okay, Victoria just said she switched to her phone. Okay, so she'll join us back in a second. But any thoughts on what this could be? This kind of narrowing. I was actually thinking about a case that Nellie showed, where there was, she showed diaphragm disease in a patient with NSAID-induced strictures. And so I looked in her history to see if she was on NSAIDs, and she was not on NSAIDs, but I was pretty convinced that maybe, and then I saw that she'd had a history of partial small bowel obstructions before. So some people are saying, do you have a coronal view? Okay, Dalal says NSAID-induced enteropathy, which is what I was thinking about. I don't have a coronal view. We were wondering about serosal disease, angiodysplasia. Good, excellent. So I look in the notes and come to find out the patient actually had gotten external beam radiation for metastatic lymph nodes in the aortic bifurcation region. And they did a small bowel enteroscopy with biopsies, and she had multiple strictures of her jejunum that were thought to be ischemic and possibly related to radiation. So this is what we thought was radiation-induced enteritis. And just have a couple of points about it here. So radiation-induced enteritis, you basically get it if you're getting a high dose of radiation. So for example, above 50 grays. And it's also if you it's more likely to get it if you have chemotherapy. The reason why is because basically there's cell death that causes mucosal ulceration, and this will cause submucosal edema. So one of the biggest findings of radiation enteritis is thickening of the bowel. This can lead to fistulae and eventually fibrosis. Another thing that can happen is you get end arteritis, which can lead to chronic ischemia and eventually strictures. So for example, this is one from the literature where we can see that there's stricture formation. So I think that's basically what happened in our case, because the pathology showed that there was ischemia-related enteritis. Rupa was asking if there was a pill retained, and we were thinking about that for my case, like is that little structure in there a retained pill cam? She did have a retained pill cam in her duodenum that was retracted, and we were wondering if maybe this was one of those like patency capsules, like a portion of a patency capsule. It doesn't look like, usually a pill cam is actually metallic, so it'll create a lot more artifact than this. So anyway, when patients get radiation enteritis, they'll get this edema, they'll eventually get strictures. Some of the symptoms are diarrhea. This is because you're kind of denuding and altering the surface, the mucosal surface. So this is one of the longest term, both in short-term and long-term symptoms. They can also get small bowel obstruction from strictures, malabsorption because of the mucosal abnormality, and GI bleeding. And the treatment is usually conservative. They don't usually want to go in because it's there's a lot of fibrosis and inflammatory change here. But they may put them on a low residue diet. And then one thing that I learned about in my case, my patient actually was treated with hyperbaric oxygen. And so just a couple of notes about hyperbaric oxygen. So I actually did my internship in Hawaii, and I did a whole rotation at this hyperbaric chamber. So this was the hyperbaric chamber that I got to spend some time in. And most of the time in Hawaii, we were using this for scuba divers who had the bends. So basically, they had nitrogen oxide bubbles coming out of solution, and we wanted to put them back into solution so that they weren't having all these symptoms from the bends. And so we'd go into this chamber. They would reduce the pressure as if we're going to the depths of the ocean, put the nitrogen back into solution, and then slowly bring them back up so that it treated their bends. But this also can increase oxygen delivery and improve wound healing. So now they're also using it medically for a variety of things like carbon monoxide poisoning, various chronic infections, and also for radiation-induced injury. So this patient, my patient who had radiation enteritis, actually ended up getting 40 rounds of hyperbaric oxygen therapy. And so when they're medically doing it, they'll have the smaller chamber and they'll put them in the chamber and then basically give them bring the atmospheric pressure down and give them hyperbaric oxygen. Any questions or comments? Rupa says, how cool, Hawaii. Yeah. So actually, it was funny. The first time I went into this chamber, I didn't know that I would have to stay in there for hours. I went in with somebody who had the bends, and it was like my first day on the rotation, and they were like, you want to go in the chamber? And I was like, sure. And then I ended up having to spend like 6 or 7 hours in there with the patient as we went down. And actually, when we went down to like, I don't remember exactly what depth we went to, like as far as pressure, but your voice gets very small. So it's as if you've like ingested helium, and then you start feeling nitrogen narcosis. So you feel a little like woozy and kind of like, as if you're like, you know, tipsy or drunk or something. And then they slowly bring you back out of it. So it was pretty interesting. Okay, my next case is this HSG. So you can see that both of the tubes are starting to look, they look normal proximally. And then distally, you can see this looks abnormal. And then also that there's like something forming over here, and then something also over here. And this was my final image. So you can see that the right tube looked like this in the end, and the left tube looked like this. And then there was also this. So any guesses on what this is? It's not too much of a mystery case. Okay, so we've got a lot of guesses for SIN, salpingitis isthmianodosum. I actually wasn't thinking that. I thought that usually affects more proximally, where you get, I'd love to learn from you guys about what your understanding is. This patient had a history of endometriosis, and they knew on pelvic ultrasound that she had hydrosalpinx, and she was undergoing IVF. And so basically they wanted to know if her endometrial cavity was still communicating with the fallopian tubes. And this was something I wasn't aware of, but basically hydrosalpinx can affect your fertility and can affect IVF treatment. And then actually this was just venous intravasation for residents, or, you know, like basically there was so much pressure in the hydrosalpinx here, which were this like kind of dilated, no free spillage, dilated outpoachings of the distal tubes bilaterally, and then this venous intravasation. So just a couple of points about this, which is basically that hydrosalpinx can impair IVF. So the fluid from the hydrosalpinx, which is kind of like this, you know, just stagnant fluid, can actually go into the endometrium, and it can impair implantation and also reduce the pregnancy rate by about 50%, and also significantly increase the rate of miscarriage. So one of the things, so in this case, this patient knew that her tubes were blocked. We weren't trying to prove that they were open. We were basically just trying to see if the hydrosalpinx were communicating with the lumen, which they were. If that's the case, they'll either surgically clip off the fallopian tubes, or I found this one paper that was interesting. These were interventional radiologists from Korea who were going in with transvaginal ultrasound and sclerosing the orifice of the tubes. And they had as good of a success rate as a salpingectomy. One of the things that they cited that was dangerous about salpingectomy is that you not only is it difficult because there can be a lot of adhesions, but it can also cause ischemia to the ovary. So one, I want to ask you guys who are talking about salpingitis isthmianodosum, did I misdiagnose this? Like, is this, what would you say is your summary about SIN? My impression was that it affects more proximal tubes. Hello?
Hey, I think you're right, and I also we don't quite see those little outpouchings that we're supposed to see with SIN.
Yeah, and then Rupa's saying is more beaded. Yeah, I thought the proximal tubes looked pretty smooth, but then when it went more distally, it was like that tube, no free spill, no beautiful like fimbriated appearance, and then this guy looked, you know, just like totally blown out, kind of no free spill.
Right.
Okay, well, I'll have to read more about SIN, but anyway, that was that case. And I think, you know, our IR people aren't doing sclerosis of these, but that's kind of an interesting concept that you could sclerose them to block off the tubes. And then I'll just do one more case. Okay, this is an eye test. So Okay, and this patient also had this very large uterus, lots of what I thought were fibroids, some of which were calcified, not the kind of irregular appearance like in Gitanjali's case. I didn't think it was a sarcoma necessarily. And then we've got our liver lesion here. So I thought that, this is in the differential of like multicystic liver mass, but I thought it looked more concerning for an abscess. It had like, hyperemic walls, incomplete septations, but also like hyperemia of the liver around it. To me, it did not look like a mucinous cystic neoplasm because I didn't see like one nice capsule to it. And I didn't see like true septae going all the way across the lesion or like nodular components. So we thought this was an abscess. And she ended up going for drain, and it was an abscess, and I'll tell you what it grew out in a second. But an interesting other, Rupa's asking if there was any travel history. There wasn't. It was really interesting, actually. She had a history of like 1 month of like fever and like vague pain. So one thing you know here that there's a non-occlusive thrombus in her IVC, and also probably a tiny little thrombus here in her IVC. So normally when I look for when I see a liver abscess, I go look in the GI tract. I'm now looking for like, was there appendicitis? Was there diverticulitis? I didn't see anything in the GI tract. And then I'll look for thrombophlebitis involving the SMV and the portal vein to say like, okay, usually the organisms come from the GI tract and go into the liver. Didn't see any of that, but I did see these little thrombi in the IVC. And anyway, they drained this and it came back. I have to pull it up because I can't remember the name. Fusobacterium nephrophorum. So, and then there was this rarely extensive ID consult and note. And basically this is usually the bacteria they see in Lemierre syndrome. So Lemierre's, this bacteria is seen more in animals, but it can also come from humans. Usually you get some kind of tonsillitis and like a bad neck infection, and it leads to septic thrombophlebitis of the internal jugular vein, and then septicemia and septic emboli. This is Lemierre. He was like this famous pathologist, but also like, a clinician from France. But what was interesting in our case is they were kind of wondering if the IVC thrombi that I had just shown you were related to this kind of septic thrombophlebitis. And they were also wondering, like, is there any way this fibroid uterus could be involved here? Like maybe there was some kind of, thrombotic thing related to the fibroid or compression of the IVC, and that led to this, this abscess. We don't think that's likely. We think that somehow she probably had a sore throat that was untreated and then got septic and then kind of threw an embolus to her liver. And then these things were kind of unrelated, these thrombi here. But one more interesting secondary thing is that she then ended up she was having some cognitive symptoms, and they did a brain MR, and she actually did have, I don't know if you can see this, but there is actually a non-occlusive thrombus within one of her dural venous sinuses. So they tested her for COVID because they thought maybe she's hypercoagulable from that, and she's COVID negative. So basically, she just had this interesting liver abscess related to this unusual bacteria that usually you see from like neck infections. Okay, I'm gonna stop sharing. Any other comments about Lemierre's? Okay, I'll stop sharing. Victoria, you wanna try?
Yeah. Can you hear me better now?
Yes.
Okay. So, can you see it?
Yes.
All right. So this was an incidentally found mass in a person. I don't remember. And you can see, it's a kind of calcified solid mass. It's not really cystic. So, I'm not showing you all the images, but you can see that the pancreatic duct was not dilated. So patient had an MR. You can see that the mass is kind of intermediate signal intensity in T1. Again, you can see that the pancreatic duct is not really dilated. We'll see the T2 in a second. It's a pretty well-defined mass. It was not really very hypervascular early on. As the time went on, this is portal venous phase, this is delayed phase, you can see that it enhances more and more. This is a diffusion. You can see this is a B800. It's very dark on diffusion. There's really no restricted, there's no ADC signal, and you can see that mass is just tremendously hypointense on T2. Again, you can see the pancreatic duct is not dilated. And on delayed images, the mass enhanced very avidly. So, so it was a solid mass. It was a very unusual imaging characteristics. So at this point,
Victoria, we have two guesses from the chat box. Gitanjali says calcifying fibrous pseudotumor. Beautiful.
Yeah.
And Bilal says solitary fibrous tumor. Also great thought.
Right. So great thoughts. And the T2 hypointense is kind of like the keeper here. And calcifying fibrous pseudotumor was the path. So the tumor was removed, and this was the path. And sorry, I just want to bring up so there the calcify. These tumors are not common. Calcifying fibrous tumors are benign, and they are kind of pseudotumors in that inflammatory category, and they do calcify. And this is the most common location where, stomach, pleura, intestine, peritoneum, pancreatic pancreatic lesions are actually very uncommon. I couldn't find any radiologic case reports, but based on other reports, it seems that, this is exactly what you would expect. It would be calcified. It would have very low signal intensity on T2 because of the fibrous content. It doesn't really affect the pancreatic duct. There's no pancreatic duct rotation. So rare, but kind of interesting case. And the last case I wanted to show, this is a true case. There are dates, but they're relevant. So this was a cirrhotic patient. In 2015, there was this 11 millimeter observation. And in 2017, it was read as 11 millimeters, as unchanged. And you can see that on both examinations, there was enhancement on arterial phase, so there was non-rim aphy. There was subtle washout in both instances. And again, there was liver restricted diffusion on both instances, and hepatobiliary phase hypointensity. So this was because this was an old case, it's 2015, 2017. This was before LIRADS 2018 came out. So the original interpretation of this lesion, 2015, that was a LIRADS 4 lesion, which was correct interpretation based on at that time version 2014. And in 2017, the person who read the case considered that the lesion was stable in size, right? So there was 2 years stability, which in LIRADS is benign feature of benignity, and actually decreased the category from a LIRADS 4 to LIRADS 3. So at this time, the patient was, again, so you can see these are but notice that they're ancillary features of malignancy, which are restricted diffusion and hepatobiliary phase hypointensity. So again, just going through the table, this is a 2018 table, so slightly different from what the clinical discussion was, but basically based on the tumor, based on the table in 2018, we would apply LIRADS 5 category, but again, at the time, this was LIRADS 4 and then decreased to LIRADS 3. So patient was lost to follow-up for 3 years, and then in 3 years later, patient came back. Came back with this very ugly, irregular mass, arterial phase hypoenhancement, washout appearance, hepatobiliary phase hypointensity. I'm not showing you on this image, but actually, there was a tumor invading elsewhere. So this is actually an aggressive vascular invading HCC. And the teaching point here is that when you look at the, the application of the ancillary features of malignancy, both features of benignity and malignancy were present. So if you look at the true rules, true rules of LIRADS application, if you have answer features favoring both malignancy and benignity, you should not adjust the category. So first thing first, the category should not have been adjusted because this lesion had, of course, both answer features of benignity, which would be 2-year stability, and multiple answer feature of malignancy, as you can see here. Another important kind of point here, again, this observation based on 2018 criteria is considered LIRADS 5 or categorized LIRADS 5, which is definite HCC. So another kind of point to remember is that if something meets criteria for LIRADS 5 in appropriate patient population, the positive predictor value for HCC is very high, above 95%. So if you're gonna apply answer features of benignity, you should be very, very cautious because again, the positive predictor value for arterial phase enhancement and washout in a lesion which is over 1 centimeter is very, very high. So if you're gonna apply answer feature of benignity, you should do it with extreme caution and maybe not even do it. But this is an interesting case.
Yeah,
but
that's a really
again,
good point.
Yeah. So, but as a kind of like as a safeguard against doing that, if you do have, if you have, I mean, conceivably this could have been CT, in which case you would not see any answer feature of malignancy, right? You would only see sty stability. But an MR, in this case, there were multiple other features present that kind of safeguard you from decreasing the category inappropriately. But anyway, so those are 2 teaching points in this case.
Cool. I have one more case. Does anyone else have cases? Okay, I can show one more. Hold up. Okay. So this was a patient who had a trauma about 9 months ago, 9 months before this exam happened. So what do you guys think? I'll put it on, trying to change my window here. Yes, diaphragmatic rupture, excellent. So an interesting part of this is that they were discharged 9 months ago, basically being told, they had some injuries, but basically they were not diagnosed with a diaphragmatic rupture at that time. And as you can see now, this is their stomach. So the entire stomach has herniated into the chest and has volvulized. So this was an organoaxial volvulus. You can see this huge air fluid level. And we can also see that some of the small bowel loops have been pulled into this hernia, and there's like a swirling appearance here. So they're all being swooped up into the chest here. So the patient ended up getting an NG tube, and this was their imaging after they got the NG tube. This is the oh yeah, Victoria asked for a coronal. I do have a coronal, but this is basically after they got their NG tube. So you can see the NG tube in the stomach, and it's going, and the stomach is now decompressed. Even though it's still flipped up on itself, it's still it's completely decompressed. And now this is what the small bowel looks like. Those small bowel loops that had been dragged and kind of like had that swirled appearance as it went into the chest now look like this. And I'll show you the coronal. So you can see this is the defect here. These are the mesenteric kind of vessels, and this is actually like a string on balloon sign. So you can see all these like vessels being pulled up, and then all these dilated loops here, which is, yeah, Dalal is saying closed loop, and that's exactly that's what string of balloons is. So usually you'll see a cluster of dilated loops, and then you'll see like a string of vessels kind of being pulled into it. So we called this a closed loop obstruction from those small bowel loops. So my theory is that basically we had a volvulus on the prior. Let me see if I had a coronal on the prior, but I just have the axial, I don't have the coronal, sorry. But that we had this volvulus, and then once we decompressed the volvulus, it actually allowed more of the small bowel loops to go into the chest. And then there was like a narrow neck there, and so then they got obstructed and it was a closed loop. So my teaching points are here. So basically this was a diaphragmatic rupture. These are usually from motor vehicle accident or blunt trauma. And they're often missed initially, and so they can have a delayed presentation. So you want to be really careful if you see any injury early on. You want to be very careful to see if you think that there could be a diaphragmatic rupture, because even a small rupture can sort of increase slowly over time and then present months later as a huge diaphragmatic herniation. The left is affected more often than the right because the liver buffers the right side. And they're usually about 10 centimeters in length. So the defect in the diaphragm is about 10 centimeters. And then these are two of the main signs for a diaphragmatic rupture with herniation. One is the hourglass sign. So you can see like this is, for example, part of the stomach has herniated up, but part of it is still within the abdomen, and the defect is small, but it's kind of slowly wormed its way up here and then gotten obstructed. So this is like an hourglass. And then this sign I think is really helpful. It's called the dependent viscera sign. So normally, if you have your diaphragm here, you should see small bowel loops below the diaphragm, and then you'll see a diaphragm, and you'll never see a small bowel loop basically like immediately touching a rib. There's always like diaphragm and fat in between those two. So if you see like the small bowel loop actually touching the ribs here, especially in the chest, that's called the dependent viscera sign, and that's a sign that the diaphragm has been ruptured. So just going back to here, all of these small bowel loops, like there's nothing in between them and the ribs. So that would be a dependent viscera sign there. And they did go to the OR, and actually the small bowel, the closed loop obstruction was there for the small bowel, and it was ecchymotic, but they were able to save it. So this, oops. This was our closed loop obstruction and our dependent viscera sign again. Okay, that's all I have. Anyone else? Okay, well, have a great day. See you later, guys.
Thank you.
Thanks, Aarti.